All right, Fiona Rogers. I've been meaning to talk about this topic for so long, and I always think about you when I think about this topic. And I'm so honored that you said yes when I asked you to be with me today. And we managed to find a time that works for us, me in Western
Mm.
Canada, you in Australia. So I appreciate you being here today.
Thank you, Melissa. And it's an honor to be asked to actually join your podcast and also talk about one of my most favorite topics to talk about.
I'll be honest. So we like as pelvic health physios, we get so many referrals, I think, for overactive bladder and urgency. And I'll be honest, I have not used TTNS enough. And it was because,
Mm.
we talk about the pelvic floor, we talk about habits, we help people understand their body, how their brain and their bladder works together. And there's a lot of education involved. And a lot of times that goes a long way to help people. But there are times where I
Mm.
get stuck and I'm like, okay, what am I missing? Because I don't feel like I've helped this person. And it was when I was taking Taryn Hallam's research update recently, and she was talking more about TTNS and how it's moving up in the
Mm.
literature as far as like a recommendation. I thought, I do not use this enough. And I think that I kind of came from a time in physio where
Mm.
we like poo-pooed modalities a little bit. And
Yeah.
I know you're going to have a lot to say about that and how much this can, help and help us learn a little bit more
Yeah.
about it. But Fiona, before we jump into that, will you please tell everybody a little bit more about you, so they know a little bit more about all of your wisdom?
Oh. Well, I'm Fiona Rogers, and I am a physiotherapist from Australia. And I come from the pre-poo-pooing the modalities era. I've been a physio for 40 years now, and when I went through, we did a lot of electrotherapy modalities. So I ended up in pelvic health physio probably about 25 years ago after my second child was born. So I was initially a sports musculoskeletal physio. And then, my career sort of took a U-turn, and I found my niche, I guess. And then 12, 13 years ago, my husband, who is my business partner, and I purchased a company called Pelvic Floor Exercise, through which we sell products. So stim machines, dilators, you name it, we sell through that, and a lot of resources. And so I started getting a lot of questions about using TENS machines and stim machines and so forth. So even though I had a background in it, I thought I needed to upgrade my knowledge, and it kind of went from there as to where I've ended up now, running courses, etc., and teaching about the use of electrical stim and neuromodulation.
And I think it is something that, like I said, I think that, we always see different trends, right? And I think that,
Mm.
sometimes we don't, I'll say for myself, and I think a lot of other physio listeners will agree that there's just so much information at the beginning. And so,
Mm.
some of it really sticks and some of it doesn't. And I think that the longer you work in the area, you start to kind of get to know more about your different treatment options with people. And yeah, like I said, I just it never landed with me using tens for overactive
Mm.
bladder. It just didn't, and I didn't feel like many people around me
Mm.
were using it, so I just didn't understand. And I think you start to get to a stage where you open your ears a little bit to like what other options are out there and start to listen a little bit more to the research and new
Mm.
things coming out. And so I I've been using it a lot more lately, like, what we're going to talk about a little bit more for people with urgency and frequency. And I get a lot of those referrals, and I'm sure other physios in my community or other communities lately from urologists. And before they'll do much of anything else, they say, I want you to go see a physiotherapist. And so this is a treatment option that when I propose it to someone, quite often they're like, what? I'm going to do what? And
Mm.
so I've often thought if I could have a podcast episode to share with clients so that they better understand it, because you need to understand
Mm.
something sometimes to adopt that. But I
Yeah.
know there's going to be a lot of other therapists and professionals too that are really interested in this because I think it carries a lot of mystery. Yeah.
Oh, I think it does. And, for a very long time, it was considered a last resort. So,
Yeah.
up until recently, which is very exciting. So, we'll share that later. We'll
Yeah.
get to that. But yeah, it was definitely, everything else, I suppose we'll try some tens. But the research in probably the last, I'd say, 5 to 10 years has just escalated in this
Yeah.
area, and that's probably off the back of the sacral nerve stim and the PTNS, which is the percutaneous route of sticking a needle in next to the tibial nerve, but that's invasive and costly, and patients have to go to the clinic every week to get it done. So the fact that we've got good solid research showing us that doing it transcutaneously with an adhesive electrode on the outside of the leg, oh sorry, the inside of the leg, we can teach patients to do it. They can take the machine home and do
Yeah.
it themselves. So we're handing some self-efficacy over to the patient. They're much more in control because, as you know, when you've got a condition like overactive bladder, it's very control your life, and it's your quality of life can be very affected by it. So I just really feel too, if we can offer something else to patients that we know works for them to then be able to do at home themselves, it can be very empowering.
Absolutely. So let's
Mm.
describe this for people. So, um, can you start with just because I keep just using the acronym TTNS. So can you describe like
Mhm.
what is that and like
Mhm.
how do you describe it to your clients? Like what does it look like? And
Mhm.
what exactly is happening that we would use it for these symptoms?
Okay. We say TTNS because it's a complete mouthful to say transcutaneous tibial nerve stimulation.
Yeah.
I have a lot to say about the nomenclature as well, because there's also, as I said, PTNS, which is done percutaneously with a needle, but it can become very confusing. And any clinicians who are listening, because in the literature, people call the tibial nerve the posterior tibial nerve, which then is also shortened to PTNS. But then you
Right.
don't know if you're applying it, via a needle or by externally adhesive electrode. So you have to be very careful when you read the research. And we really there's no posterior tibial nerve. It's the tibial nerve. It's the same nerve. It just, what are we calling it? And again, for clinicians, there's a really interesting paper by Moretti et al. 20. I'm not going to quote the year, not that long ago, where they actually try to, they go through the nomenclature and suggest that we should be sticking to tibial nerve. So your tibial nerve sits on the inside of your ankle, and it's basically at the end. Most people are aware of their sciatic nerve. So the sciatic nerve branches off into several nerves, and one of those at the end is the tibial nerve. So the way I like to describe, whether I'm using it for overactive bladder or for pain or for anything, any a TENS machine, I usually explain to my patients, if you think of your brain as your nearest city. So for me, my nearest city is Brisbane in Australia. And then if you think of your spinal cord as the main highway leading to it, and for me, that's Bruce Highway takes us down to Brisbane. And then you've got your feeder roads, like your motorways that feed into that main highway for you to get to that city. So I just sort of say, if you think of a traffic jam or something going wrong and information can't get through, or if we want to put some information and flow that traffic through in a different way to get into the central nervous system, what we're doing with TENS is we're just putting in a different input so that it can be interpreted differently, perhaps by the central nervous system. So we're putting in that nice sensory information, and it travels along the tibial nerve, and which goes up through the sciatic nerve, and then that is branches off from the area in the bottom of the spinal cord, which controls your bladder and bowel, basically. So what we're trying to do is change that input, if that makes sense.
Yeah.
So we're putting a nice calming input. So if you think about the techniques that you use for bladder calming, we often talk to patients about curling your toes or going up and down on your, getting your calf muscle working. Often talk about pressure on the perineum, or a good one that works for my patients is rubbing the back of your leg. What you're doing with that is you're putting traffic through those motorways that are leading to that central point. So there's less traffic going to the bladder that's in very sort of lay terms. So what we're trying to change that input, and TENS is just another way of doing that. We're just putting a nice sensory input in through those pathways, To be honest, if you speak to the surgeons who do the implants with the sacral nerve stim, etc., we're not 100% sure about how does it, because we can use it for overactive bladder and underactive bladder, and we can use it for some of the bowel conditions as well. So we're not really 100% sure how it works, but it's thought that it affects those reflexes that happen in that the sacral area of the spinal cord that controls the bladder. So again, I like using, I just find patients really relate when we use sort of stories to tell, how things are working. If you think of the traffic lights, and we're just changing the direction of the traffic with traffic lights is how I often describe it. So it
Yeah,
helps to calm the bladder down. Yeah.
and I think like some people will have used TENS before for maybe their back or some people in labor, but for
Mm.
anyone not
Mm.
listening, yeah, it just feels like kind of a nice pins and needles. It's a nice sensation, right?
For most people, and some people it takes a bit of getting used to. And it also depends what level of hertz that you're using. So it can feel like that really strong pins and needles if we've got it up high, or if we're using a very low hertz, it'll feel more like a tap, sort of
Yeah.
tip, tip, tip. And yeah, it's really quite a pleasant sensation. It's and it's easy for people to apply. So just sort of backtracking to what you asked before, all we do is we pop two electrodes. I've actually got a couple here. If anybody's actually watching this rather than just listening, we use these adhesive electrodes. Generally, sorry, we can see those. These are 50 by 50 mil ones. You can, depending on the size of the patient, we might go a bit smaller with the electrodes. We pop one of, if you look at the inside of your leg and right down the bottom at your ankle, there's a lump called the malleolus. So what we do is we pop one of those behind there. The second one goes roughly 10 centimeters or a couple of these pad widths above. And the reason is that tibial nerve, as I said, leads up to the area that helps to control the bladder. That's where it's what we call the most superficial. So it's closest to the skin at that point. So no point in us trying to get to it sort of at the back of the leg, because there's a lot of muscle and fat tissue between the outside world and the nerve. So what we're trying to do is get that input to it where we will get the best dose, basically. So the closer we are to the nerve, the more input we're going to get, which is also why the percutaneous, sticking a needle in there and getting that needle right next to the nerve, that works really well because we're much closer to the nerve, but they only need a much smaller dose to do it. And as I said, not everyone can go have that sort of treatment available to them, and it's invasive, and there's a lot of reasons why some people might not be able to use it. So if we can replicate that, and again for the clinicians out there, and obviously patients will be interested, we have really good research now showing us that there's what we call equal efficacy. So they both have equal effect. So if you can do it yourself at home, much easier and cheaper way of going.
Absolutely. So where would you normally see the percutaneous option being administered? Like where would someone find out about that in their community?
I can only speak from my experience
Of
here in
course. Yeah.
Australia, but you need to be going like either a urologist or a urogynecologist will be doing that here. I know in some areas of the world that physical therapists or physiotherapists do it because they are advanced practice in doing like acupuncture,
Yeah.
and you can sort of stick the needle and then you can attach the TENS machine. It's not in scope of practice here in Australia, and I know that there's only a few places I believe where it is actually scope of practice to do that. But again, the patient still needs to go to the clinician to do that. And here it can be a big wait for us to get in to see a specialist. So you go to your general practitioner who will then refer you. So it can be quite a long process. So in the meantime, again, as you said before, a lot of our doctors here will refer patients to go and see the physio first. They can work on, bladder training, all of those things, pelvic floor training, because they're all of these other treatments are adjunctive. So even TTNS, it's adjunctive. Standing alone by itself, it's not going to cure you. It's just it can make a huge difference, and it can be the thing that gets you over the line. But if you still have really poor bowel habits, and if your fluid input is too great or too little, or whatever reason that is causing your overactive bladder, that needs to be addressed as well.
course.
So, but yeah, you need to see a physician normally to get the PTNS.
And I think that's again, we have to our advantage as physiotherapists is more time. And so the chances
Oh
of your
yeah, yeah.
urologist or your doctor administering or educating you about the TENS option, the TTNS option, like I think that's why often like in Canada, the appointments are like 10 minutes. And so that's why quite often they say go see a physiotherapist. And then
Mm,
I just make sure that I send a letter back to the, because I know sometimes it's just educating the doctor that our letters do and
absolutely.
let them
Mm, yeah.
know these are the things that I've worked on. Because I think a lot of times they look at that and be like, oh my gosh, I just didn't know a physiotherapist would do that. And so I think it's a big thing we can do as therapists to educate the providers in our community. And I often send a note to the doctor, even if they haven't referred, just because using it as a way of
Oh
education
yeah.
for the physician. Yeah.
Absolutely. I've been lucky enough to be invited to speak at a number of medical conferences here about TTNS, and often it's in a workshop situation where there'll be a surgeon who does the PTNS and then another doctor talking about medication and someone talking about the IPGs. And without fail, every doctor in the room is so intrigued, and they come up to me afterwards and they say, wow, I had no idea that you could do this, with a TENS machine. And so many of them, they're not like, well, this is my territory. You can't be
Yeah.
doing this. They're all very collaborative and very keen. And, a lot of them then start referring on to their physios because, as you say, they don't have the time either in their consults. They have to look at the medical side and work out what tests are needed and so forth. They don't always have the time to go into the bladder habits and all the stuff that we do with our patients. And that's why working collaboratively as a multidisciplinary team is really so vital with conditions like this.
So why is it then that the average person or practitioner hasn't heard much about this? And I think maybe you've answered this by the fact that the research is just really exploding in the last few years. Was it just that there wasn't enough
Mm,
research? And I know it's hard for research to make it to clinical practice, but like why, like,
yeah.
why is it such an
Mm,
eye-opening thing when you go talk at those events?
I honestly don't know. I think I've thought about this, and I think possibly because OAB has such a medicalized condition. So the thought, people who we would normally go to see, like urologists, etc., they've got their lane, their things that they look at. And then the surgeons who might be, doing an implant or whatever, their focus is surgery or the medication. That's what they've been taught. So I think probably because it's so medicalized, and now with more of this research coming out, that we're starting to spread that word that this is another area that can be used in treatment. And I think what's really helped that is that we now, the ICS 7th edition that came out has now put transcutaneous tibial nerve stimulation up into, woohoo, the first line of treatment. So it's up there with behavioral therapy, physiotherapy, pelvic floor muscle training. So it's now considered where it should be, which is in that first line of treatment options. But having said that, the NICE guidelines in the UK from 2019 still state do not offer tibial nerve transcutaneous tibial nerve stimulation to a woman with overactive bladder. And that they came out after the Booth systematic review was published, I think 2018. The one that I was involved with did a scoping review, and we looked at all the papers that have been published since that Booth systematic review. But those guidelines have not changed. So I'm hoping that in the coming time that other guidelines will catch up with the ICS basically.
So
So yeah, we're getting there.
So I know that you were involved in this is big scoping review. So was that scoping review like leading to the ICS recommendation? Or like can you explain that to people? Like what exactly is a scoping review? Like you explain that so people understand. Because I think sometimes,
Okay.
sometimes it's hard for people to understand like that all of these recommendations are based on research, right? We're not just pulling these
Mm.
things out of a hat, right?
Oh no, absolutely. Yeah. So I mean, we have systematic reviews, and normally they'll have a meta-analysis. So you've got to have enough data that is homogenous or the same so that we can compare it, so that we're comparing apples and apples, not apples and oranges. A scoping review doesn't go into the meta-analysis so much, but what you look at, with either of them, you choose your topic and then you search for papers in a certain time frame across all areas where research papers can be found, and pull all those papers down, and then very laboriously, you set your criteria for what you want to look at. So you have to go through all those papers to see if they match your criteria. Are they looking at what we want to compare? And then you usually end up with X number of papers, and the team that's doing the review read them, pull the data out of them, and then start putting the comparisons together. The problem with all of this is a systematic review, a Cochrane review, any of those are only as good as the research that's been done. So you could pull 10 papers down and you can only compare the data that's in them. And unfortunately, up until now, and this is changing now that where things are sort of looking more at what we call homogenous cohorts of patients. So people who've got very similar conditions, whereas previously all of the research that I've ever read on overactive bladder and tibial nerve stim and PTNS is that they do it on patients that have failed previous treatment. So they've had conservative treatment, they've been through medication and they still haven't improved. Oh, well, let's try some TTNS on them now. And they were still improving. So what we're now looking at is patients, trying to do research on patients before they get to that stage, what we call recalcitrant. So, it's not responding. And that's the general gist of the research, is that if we can get people earlier, that we will probably get better outcomes. However, it then depends on the pathophysiology of their OAB. And that can get really complicated. It's probably not the topic for, a podcast, but we have generally OAB wet and OAB dry. So people who have OAB dry are those that get those terrible sudden urges, but they don't actually leak. And people who are OAB wet get the urge and then they have a bit of a leak. All of those have been grouped in together into the same research groups, and we're expecting to get the same result, or compare results, but they've got different pathophysiology. So what we need now is to be looking at groups that are the same. So just looking at OAB wet, OAB dry, etc. Then you've got things like neurogenic bladder, so people with spinal cord injuries, multiple sclerosis, Parkinson's disease, etc. They've all been lumped in together. And, a lot of the papers will also look at mixed urinary incontinence. So they've got some stress incontinence as well as urge incontinence. So you can see this picture, there's so many reasons why people have bladder leakage. And what we really need to look at research-wise is putting people into, just researching a group that have the same symptoms and pathophysiology, which is the cause of their overactive bladder. Does that help explain it?
Yeah, and I think I
More?
think
Yeah.
I think when you talk about all of that, I guess what I'm trying to get at is that, it keeps moving up as far as, like you said, a first line treatment option.
Yeah.
But let's just clarify, first line treatment option for overactive bladder and urge, correct? Like, well, overactive bladder.
Well, first line comes a pelvic floor muscle training is in there as well. So I think if you're a clinician, you really need to work out, is your patient overactive, OAB wet or OAB dry, and then you need to look at what is the cause of them leaking. So for some people, it will be that really strong urge, and then that causes a bit of bladder neck funneling, which then triggers off the micturition or the voiding reflex. So you get a bit of a leak. For some people, they don't get that leak. For other people, they may have a bit of weakness. They may also have a bit of stress incontinence. So when they get downward pressure on the bladder, their urethral closing pressure, ability to close it isn't as great as it should be. And again, that's a whole other topic of is their external urethral sphincter a bit weak? Is their estrogen status, if we're talking about a female, if we're talking about males, they could have to do with their prostate, etc. So there's a big differentiation there between, like, you've got to put your clinical reasoning hat on when it comes to this. And what I find generally, whatever we're talking about with stim machines, whether we're doing muscle training or calming of things, put a machine in someone's hand and their clinical reasoning can often go out the window. Like, it can be, oh, what do I do? So you'd still need to use your clinical reasoning and then sort of decide, is it going to be helpful for me to add something like TTNS in? But the research is basically telling us that yes. Having said that, if someone came to me, it's their first session, I'm not just going to hand them a TENS machine and say, off you go, we're going to do this. You do your assessment, work out, if we can work out what's happening, the cause of their OAB. And then I would always go through their bowel habits and give them get them to do a bladder diary. We look at what the urges are, like what level is it. So it's that sensation-based urge, what volumes they're doing. We go through all of that and then start their bladder training techniques relevant to what the results of that is. And then down the track, maybe the next session, if they're not improving or they're doing well, but we feel we need to give them more, that's when I would tend to introduce it. For some patients, you do your initial bladder diary, your initial training, they come back in a few weeks and they go, oh my gosh, I'm so much better. And it's just that all that education and awareness, and it makes them realize that they don't have to rush to the toilet at that first sudden urge, etc. So it's, when you introduce it, it's very patient dependent, but we really should be introducing it way, way earlier than we were. And because it's non-invasive, it's cheap, you can't overdose on it. The only side effect that you will get is some people get a little bit of skin irritation from the adhesive on the electrodes. And, there are hypoallergenic electrodes that you can buy if anybody is getting that reaction with it. So I have had a couple of patients have like a autonomic response, like feel a bit increased heart rate. I had one lady who felt that her blood pressure was changing, but I think it wasn't direct. She blamed or felt it correlated with doing the TTNS, but I think it was more like a stress reaction. So, you do have to monitor things, but really the only side effect is going to be someone getting a bit of a skin reaction.
So what I've tended to do, I think every clinician would do this a bit different, but what I've tended to do when I start thinking, I wonder if this would be an option, is I usually, show them how to administer it in the clinic. I
Yeah.
help them put it on. I send them home with a detailed like email of kind of what it does,
Yep.
how to set it up. I'll have it on while I'm there. We're doing maybe some education while it's on.
Yeah.
And
Great.
then I don't send them home with my own machine only because I only have one in the clinic. So then I show them, give them some ideas of where to purchase one. And we go from there. What do you tend to do? Do you, because again, this can be patient specific or clinician specific, but just
Mm.
suggestions for other clinicians listening.
It's a lot of clinics here tend to have like a few machines that they will hire out to the
Yeah.
patient. When I do it, I like to see them again in a couple of weeks,
Yeah.
and just to make sure that they are still using it correctly, because I've had patients come back and the electrodes aren't really where they should be,
Yeah.
or they've fiddled with the machine and they thought, well, they'll try different settings. Any use of TENS, we have to dose it correctly. And I think this is also where a lot of clinicians give up on it, basically, for that and for pelvic floor, like if we're talking NMEs, because it may not have worked for the first patient they used it on. So I think, oh, that's not going to work. So I'm a big believer. You need to understand the principles to be able to apply protocols. If someone emails me, what's the protocol for this? I won't give it to them because it isn't. Like if you understand the parameters and how to use them, then you should be able to work it out. When it comes to TTNS, so there is a range that we use, and the classic range to start on is 10 hertz with a 200 pulse width. But yeah, your patient will sometimes come back. They've changed that, and you don't want to leave them. We usually like to try at least 6 weeks, so we should be getting some improvement seen in a responder within that 6 weeks. And most of the protocols will go for about 12 weeks, but that is matched up with PTNS because a lot of the research on TTNS has been done at the PTNS parameters because all that research was done first, and so they do it at a different parameter level, and they do it once a week. So the fact that we still get good results with TTNS or equal results using those timeframes just goes to show how effective it really can be. when if we use it a little bit more frequently every couple of days at home, we can still get excellent results. So yeah, I would tend I do all my assessment, and we've decided to do it exactly what you say. It's great to pop it on the patient in the session so that they can sit there with it on, feel what it's like. We continue talking and doing some further education, whatever might be coming up in that session, and then send them home. So with a higher machine and get them back. And if they feel committed and want to continue doing it, then we would normally get them to purchase their own machine. So on machines, again, I mean, I can really only speak for what's available here because around the world, different machines are available.
Yeah.
So rather than actually say a particular machine, there are two types. There's a digital machine and there's an analog machine. So the digital machines, they're always more expensive, but they're more accurate. And so with a digital, you've got the digital screen on them, and you can set the exact hertz and the exact, with your milliamps or intensity, it goes up in like 1 milliamps at a time. And you've got a lot more control. So as long as you make sure that the machine you're using allows you to set the correct parameters. So you will get a lot of machines that come with preset parameters, and a lot of the ones that are aimed at pelvic health, all I'll say is that they are not necessarily appropriate. I've seen a lot of them that have the correct hertz and width, but they've got a duty cycle of on for 5 seconds, off for 5 seconds. We need this on continuous with when it's tens. So you're halving the dose. So just harping back to a point before, I always sort of lose my train of thought here, but you need to dose any use of tens the same way you would dose medication. Like if you don't take the correct dose of medication, it's not going to be effective. So if you don't dose your tens correctly, it's not going to be effective. If you give a patient some exercises to do, for example, let's say we're doing knee extensions to build up their knee, their quads post-op. If you give them too much and they go home and do far too many exercises and come back to your next session, the knee's sort of all swollen up and it's sore, you don't say, oh, well, exercise doesn't work. What you say is, okay, we're doing too much. Let's reevaluate that dose and pull the dose of how much you're doing back, or vice versa. You increase it if they need to progress. So it's the same thing with using tens. We need to be able to control the dose that we're giving them. So that, just sidetrack from that. Coming back to the machines, we've got a digital machine, but we've also got analog machines. So they're the little ones that I've just got a little example of one here. Most people will be familiar with this sort of machine. Oh, it's really hard with that. And you just pull the down. And so you can see you've got the little buttons there. It's a bit of an approximation on a lot of these. So you turn your dial sort of somewhere between, 10 and 20 hertz, or I think that one goes 2 to 10. So you're not getting as accurate, but these are very cheap, cheerful, easy to use, and easy for the patient to use. You can't lock these. You can usually lock the digital one. So if you've got patients who like to fiddle, patient out there listening, don't fiddle with your settings. You can lock those other ones. But these are cheap and cheerful. Certainly here in Australia, we can buy one for about 50 Australian dollars, which is probably about 10 US or Canadian dollars. Our exchange rate's pretty bad at the moment. But basically, they're cheap and cheerful, easy to use. So that's what you need to get a machine that you've got the ability to set the correct parameters on.
So, and when you set those parameters, but then when they turn up their intensity, can you describe to them, what they're looking for?
Yeah. Okay. What we do, and in fact, if you like, I can send you, I've got a video that goes through setting up both
Beautiful.
a digital and an analog,
Yep.
and it goes through the whole thing. And I have a lot of people that send that to their patients because it's something that they can follow visually. Excuse me. But what we do is we place the electrodes along that tibial nerve. So the best way to get to it is, as I said, just behind the malleolus, or that little lumpy bit on the inside of your ankle, and then just behind the shin bone, about 10 centimeters up. When you start to turn it up, you will start to feel that sort of tingly feeling. What we're looking for is to make sure that we are on the tibial nerve. So we take it up, until we get what we call a motor response. So we start to see either the big toes sort of starting to tap like this in time with the hertz, which is 10 hertz, or we'll see a bit of a splaying of the toes because that's the motor innervation of the tibial nerve is to the toes, basically. Some people will not get that splaying. So I get people contacting me, oh, we were up to like, 25 hertz or whatever, and we're not milliamps, we're not getting that. So not everybody will get that, but as long as they're getting a very strong sensory sensation along that line, which of the tibial nerve, which is sort of in that under part of the foot and around the back of the ankle there, then you can be pretty sure that you're on it. You then turn it back down. So if you've got some motor response there, like toes curling or splaying, you then just dial back the intensity until those toes relax. So you want the sensation without the motor response. Having said that, if anyone's listening to this, there is a research paper out there that compared the two, taking it up to motor response and comparing it to sensory. They got the same effect. So I don't really see the point in having someone with their foot like this the
It's
whole
uncomfortable.
treatment. It's going to be very uncomfortable. So so that's basically what we do. Some people will not get that because their sensation isn't good enough. So before you start using it, you should always do a sharp blunt test. So if someone's got peripheral neuropathy, where the sensory nerves, the input from the sensory nerves, they've been affected, and often you'll see that in, say, in diabetics. They may not be able to feel that sensation as well as they should, or they may not be able to feel it at all, in which case you shouldn't be doing it on that area. But think about that pathway. Think about the any traffic going anywhere along the any of those motorways. You can bring it more proximal or closer, so we can come up and do it around the sacrum. There's a lot of research going on about doing it at the back of the knee on the perineal nerve, but it's a little bit deeper. But there is some good research coming out, so there's going to be a lot of options in the future. But yeah, and you can do it internally as well, because if you use an internal electrode, you're getting very close to the pudendal nerve, which comes from that same branch. There's a lot of people it would not be my first choice because it's it's somewhat uncomfortable for some people. They can't sit at their desk or in front of the television doing it. Like, it's just another level. But there is always access somewhere along that pathway.
And so would you suggest then, like you mentioned every other day or every day, for at
Yeah,
least 6 weeks?
yeah.
And how
30
long do
minutes
you
a
tell them?
session.
30 minutes, you said?
Yeah,
Yeah.
yeah, 30 minutes.
And
So the general rule of thumb, and that's sort of what, as I said, when we looked at the research, there was such a broad range from everything from once a week to every day. And roughly around 30 minutes was the average, and that's generally what we advocate for it. And also somewhere between 10 and 20 hertz. This gets into the dosing again. I've spoken to urologists, I've spoken to people from the companies that make the percutaneous machines. Why do you use 20 hertz when that's actually at the level at which we get motor, that we start to get a tetanic contraction? Nobody's been able to answer that question. And so if we remember back to the fact that we have a needle next to the electrode, well, when you do it at 20 hertz with the needle in there, you only need a very small, maybe 5 to 6 milliamps. So it's a very small intensity to get the same response because you're closer to it. So we're looking at dose there. When you're using an adhesive electrode on the outside, even though we're as close as possible to from the outside to the tibial nerve, we still have the resistance of the skin to get through and some other tissue before that current gets to the nerve itself. So we need to have an increased milliamps or intensity going in there in order to get that depth. Or you can change your pulse width. And that gets into a whole, where I'm saying you need to really understand, if you're going to start fiddling with them, you need to understand the different parameters. But you can get a bit deeper. But that trade-off is it becomes more uncomfortable. So when you start to play with all of that, so we generally do 10 hertz so that we can get those milliamps up high enough to get enough dose through to that tibial nerve when we're using it transcutaneously.
do you normally tell people that they should assume that they need to modify that intensity or increase the milliamps within that 30 minutes? Like,
Oh,
You know what I mean?
absolutely. Yeah, the
Yes.
patient.
So
Yeah, yeah, yeah. The
the
patient can. The clinician. It's more the other parameters are more for the clinician to understand.
yes.
But for the patient, all they need to understand is where they need to put the electrodes, and that yes, they need to increase the milliamps because if you want it at the maximum comfortable, so get your milliamps or intensity or that sensation of tingling as high as comfortably possible, and keep it there. So once it's been on for a while, often you get that what we call accommodation. So that it doesn't start to feel, you get used to it
Yeah.
basically. So you're not feeling it quite as strongly. At which point, absolutely, to continue getting that dose there, you want to turn the intensity up until it comes back up to that feeling. Oh, that's the most I can take without it being painful.
Right.
Some people may not feel the need to do that through a treatment. They may continue to feel it quite strongly. Most people will get to the point where they need to turn it up a bit. But if you turn it up too much and your toes starts to go a little bit, just drop it back so they can sort of adjust that as needed.
This is like a clinical question and based on your experience. So there's no data to support this. But when you administer this with someone or they go home with it, um, how often does it not provide any relief? Again, I know that's kind of a hard question, but are you usually pretty confident that they're
Mm-hmm.
going to get some benefit?
If I've clinically reasoned things correctly
Yeah,
and being aware of their whole medical history. So I just always say, look, it doesn't work for everybody, but when it works really well. So if we go back to the research, people report everything from like 48 to 93%, I think,
wow.
success rates. Those much higher success rates are clearly on a cohort that are going to be responders. And there's other research coming through that they're looking at doing testing on the nerve conduction to see who might be a responder so that we can maybe send those people off to TTNS or PTNS, and then if they're not going to respond, follow another pathway. But as things stand now, and as for being a clinician in the clinic, if you've done sort of good clinical reasoning and it's not more a case of they're leaking because it's more of a stress incontinent issue, then, and you've looked at all the other possible causes of why they've got this overactive bladder. So we're not just taking them in, treating them with TTNS, and saying, oh, this is going to work for you. Some people need some medication at the same time. Everybody needs behavioral therapy and all of that, sort of looking at that side of things as well. So yeah, it's sort of a combined approach.
Of
But
course.
yeah, the success rates do vary,
Yeah.
but more people are going to respond than don't, basically, if you're doing the rest of what you should be doing as a clinician.
And do you describe to those people that kind of the same as I think a lot of times we explain to clients when they say, Um, I don't know. How long is this going to last? I know there's so many things
Mm.
that depend, right? Like there's so many, it depends on
Yep,
what you're
yep.
talking about. But I think a lot of clients have that question, like, is this a permanent change? Or after my 6 weeks, if I feel a lot better from all the things you've done with me, Fiona, and
Mm-hmm.
I've used this TTNS for a while and I feel great. I feel my quality of life is great. When do I need to use it again? Or will I need to use it again? How do you
Okay.
answer that question for
Yep.
them?
Again, it depends.
Of course.
So yeah, so if you've got someone who's responded, say by 12 weeks, and what do we class as success? Are
Yeah.
they completely dry, completely no episodes? When we're looking in the neuromodulation world, when you look at sacral nerve stim, when they implant an IPG, etc., in the leads, their success rate is classed as a greater than 50% reduction in leakage, not necessarily like with urge episodes. So then we come back to, is it just the urge episodes we should be counting, or is it the leakage that we're counting? But generally, if someone has responded well and they're feeling much more in control, and let's say for argument's sake, they've been doing it 3 times a week, I would start to reduce them down and say, well, let's just go down to twice a week and for a week or two, and then down to once a week. And if they're maintaining, then maybe let's give it a break for a few weeks and see how well you're going. Most people will find that they'll find that sweet spot. So some people are absolutely fine because everything working together has worked for them. They've changed a lot of bad habits that could have been their cause of their overactive bladder, and they're fine. Other people will find, yeah, I'm good for a while, but then I find after not using it for a few weeks, I'm feeling a little bit sort of getting those urges again. We would maybe start, just do it once a week or increase it again until you're good and then start to decrease it. And most people will find where they sit as far as whether they need to do any like maintenance work. And again, that's what some of the research is looking at now, who needs maintenance. And again, clinicians, there's a really good paper that was done that looked at responders. So people who had responded to PTNS, they then took those responders, split them into two groups. One of the groups continued with monthly PTNS as a maintenance. The others did TTNS at home a few times a week. They got equal response by the end. They maintained equally. So it could be that some people who didn't quite do so well with TTNS as an initial treatment may need a course of PTNS, but then can continue their own treatment with TTNS. So there's so many options.
Yeah.
But really, I would try with them first to wean them off, get them to self-wean, see where they sit. And I've had patients in the past who just find, well, once a month, I just find I need to give myself a bit of a top up. And, this comes down to the whole pathophysiology of OAB and, is it a curable condition? Like what's causing that particular person's one? Like what else do we have to look at? So often it's seen as something that someone has to manage. So we need to find the best management strategies for them, whatever that includes, behavioral therapy. And I mean, this might be TMI, but I ever since I had my kids, I tend to have a bit of urgency, but I know the things that cause it. Like if I have more than that 2 cups of coffee a day, boom, um, and that's what will tend to trigger me. But I know I can manage that. I don't need to anymore use anything else. I've used TTNS on myself, and at one stage I was on medication after my second child because it was pretty bad. But worked through all of that. So you will often, if they've got the right information and they've worked with you, then usually you can get to the point where a patient knows what works for them.
I think that's so important too. I think sometimes people get fixated on something going away completely, and when you remind
Yeah.
them that it's
Mm.
a quality of life issue, and I'll be honest, like everybody has
Yeah.
something that they're managing, and I'm always
Yeah.
surprised, like when you ask people when they, oh, I had a man the other day that he was getting up 4 to 6 times a night to go to the bathroom, and we saw each other, I think on the third appointment, he said, I'm down to 1 to 2 and I can live with that. He said he wanted to move on to
Yeah.
his
Mm.
next. He's like, that is not even an issue for me anymore. Whereas some people, that would be a really
Yeah.
big deal, right? And so
Yeah.
I think
Yeah.
it's important
Mm.
to keep kind of asking, can you live with this? And what does this mean for you? Um,
Yeah.
this is all very helpful. I think not, like I said, not only for clinicians, but people listening. And I think that I hope what it does is, well, it helps clinicians think, oh, I should start trying this or thinking about this, or how would I apply this for
Mm,
some of
absolutely.
the people
Mm.
in mind. And I also hope that like there's a lot of listeners that might hear about this before their physio or before their practitioner. So I hope
Mm.
they feel comfortable,
Yeah.
saying, what do you know about this? If maybe they've tried some other things. I hope that that happens as well. Fiona, is there anything I didn't ask you that you think's relevant for this discussion?
I think we've pretty much covered it all. I did make a few notes here. I'm just going to
Yeah,
check that
check
I
them because
haven't
sometimes I just don't ask
haven't
enough of the right questions.
Yeah, two things actually. I'm thinking one of the other, when we talked about how does it work, one of the theories, and I can't produce any research on this, but one of the theories is that sensation travels up to the amygdala, which controls that sort of fear response. So
Mhm.
anybody who's ever had the experience of those sudden urges, there's always that fear factor. And like, what if it happens when I'm out, and you're always very heightened. So it's almost like you become very centrally sensitized, which, we with
Yes.
pain. So that fear factor is there. And that's often what leads to people to frequently like going just in case before they
Yeah.
leave the house. I'll go just in case so it doesn't happen. So one of the theories is that part of the action is that it does go centrally, works on the amygdala to help calm that fear down. So that fear of leakage, etc.
Interesting.
So that's a really interesting point. And then the other thing is, I would really encourage people to use some form of outcome measure because we all know, and even ourselves, like if you've got a condition and you're sent away to do something, unless it's 100% better, you come back and a patient will say, oh, yeah, no, but it's still there. But it may have gone from 5 episodes a day to 1 episode a day, but in their mind, it's still not better. So if you've got some sort of objective evidence, so if you've done like a sensation-based bladder diary, or, if you're a clinician, you might want to use any of those there's 100 outcome
Yeah.
measures you can use for bladder. Make sure that you've done one at the beginning with the patient at the beginning of their treatment, and then get them to follow up. And usually that sensation-based bladder diary is the easiest for them to do. So you've then got that evidence saying, well, when we started, you had lots of those sudden level 4 urges with a very small volume, and now look, you're only getting like one a day or one every couple of days. I acknowledge that you're still getting that, so we've got work to do, but then they can physically see that improvement. So it's really,
Yeah.
I find those bladder diaries, when you do it as a sensation-based one, is just gold for patients, because they have often got no idea. Like all they've got is that sudden urge, and oh my gosh, and then I get to the toilet and I only passed a small amount, and then feeds the fear and everything. But when they see that sensation of urge only produces X amount of urine, and then when they go and they've got a more comfortable say the cup or so of urine that they pass, and it's a different sensation, I get them to really focus on that sensation, and they go, oh, so that sensation means there's this much. This sensation means my bladder's lying to me, as they often say, the bladder's an unreliable witness, it tells lies. So
Yeah.
and then once they start to see that, even just doing that 3-day diary, I've had so many patients that have come back and gone, oh wow, and now when they pay attention to that sensation, they know when that's a real urge that I actually need to go, or I don't. And that can give you like a good 50% improvement off the bat before you even think of anything else. So I just find those are very valuable. And then maybe 6 weeks down the track, they do it again, and they can actually see how much adding the TTNS has actually helped them.
Yeah. Very true. Um, yeah, no, I thank you so much for all your wisdom and all your pearls. And
Oh,
um
my pleasure.
will you make sure that you tell everybody? I'm going to make sure that I link in the show notes. I always will share where to find you, and I know you have lots of great information, but what about, I think a lot of your information will be for clinicians. Like, I know you have a
Hmm.
course and you have a very, like you have a business where you sell a lot of valuable products, but can you just tell a little bit more about what you have to offer, Fiona?
Yeah, I have a couple of courses for clinicians, and I'm actually about to revamp the main course, the electrical stimulation one, just to up bases will still be there. I'm just going to update all the research on there. I've got a standalone one for clinicians on tibial nerve stim, because there's actually other conditions that we can make use of tibial nerve stim for. And yeah, I've got on our website, we've got lots of free resources as well. So I've got pages on there that for patients to have a read of about overactive bladder and how we would treat it, and all those sorts of things. So that's under the resources and information, and we've got loads of videos on there that I've made. And one of them is how to apply TTNS. So anyone's welcome to go to that. So I can send you the link, but you go to the website and go to information, and up the top, and it'll drop down, and there'll be all these videos there. So just sort of search for it. So yeah, so I've got lots of resources there. I hang out on Instagram a fair bit, and we try to post helpful information there, because yeah, I see that as one of my roles too, is to sort of demystify. Not everybody needs a product at all by any means, but if you're going to use a product of any sort, I just like to demystify that, because it can be quite frightening for patients when they go and Google things.
Absolutely.
So I like to make sure people get the right information. And if you're a clinician, I like to get you to get the correct information about how and when to use a product correctly. So
That's great. Well, I thank you so much for
thank you.
everything you do and for your time today.
Thank you so much for having me. It's been a pleasure.